Ladies and gentlemen, welcome. Welcome again to our webinar. We have a fantastic topic, which is on disorders of sex development and endocrine conditions impact on sexual function. This is something which normally we don't discuss so much at university and in the residency, but it's something will touch really our daily practice. And today we have two fantastic speakers. They are Professor Angelica Hirschberg. She is Professor of Obstetrics and Gynecology at the Department of Women's and Children's Health in the Karolinska Institute in Stockholm. And she is a consultant gynecologist in charge of gynecological endocrinology at Karolinska University Hospital in Stockholm. Her research is focused on disorders of reproductive and endocrine function in women. The second speaker today is Professor Rossella Nappi. She is a gynecologist, endocrinologist, and sexologist at the Research Center for Reproductive Medicine and Unit of Gynecological Endocrinology and Menopause in the Department of Obstetrics and Gynecology in the Institute of San Matteo Foundation in Pavia. And you will see in your screen the possibility to put question by question and answer. The question, we will answer to the question at the end of the presentation. We will start with the first presentation and then we will follow for the second, and we will have a beautiful question and answer session at the end. Then now, please, is Angelica, if you can start, if you can take the microphone. Thank you very much.
Thank you so much. Do you hear me? Can you see
the first? Perfect.
Okay, so then I start. So I will talk about disorders of sex development, impact on identity, sexuality, and fertility. So what do we mean by disorders of sex development, DSD? The definition is congenital conditions in which development of chromosomal, gonadal, or anatomic sex is atypical. And these disorders could affect both identity, sexuality, and fertility. And all DSDs are rare conditions. And for instance, in Sweden, we have about 10 million inhabitants, and about 10 children every year are born with ambiguous genitalia and unclear sex. And now I will give you some examples. So I will start with my first case. This is a 20-year-old woman with severe hirsutism acne and oligomenorrhea. Her younger sister has similar symptoms. Her weight is 61 kilogram, height 164 centimeter. And at the gynecological examination, it is noticed that she has an enlarged clitoris by 3.5 centimeters, and she has polycystic ovaries on ultrasound. And here you can see her laboratory results. FSH 5.2 units per liter, LH 5.5 units per liter, testosterone 4.5 nanomole per liter, SHBG 91 nanomole per liter, and Müllerian hormone 1.7 microgram per liter, and 17-hydroxyprogesterone 97 nanomole per liter. So the most striking findings here are the very increased testosterone level and the increase in 17-hydroxyprogesterone. So what could this be? Well, this patient was diagnosed with congenital adrenal hyperplasia, shortened CAH. And this is the most common type of XX DSD, most often caused by deficiency of 21-hydroxylase, an enzyme in the adrenal gland, the adrenal cortex. And this is an autosomal recessive disease caused by mutation in the CYP21 gene. These individuals, which could be both females and males, they have a normal karyotype and they have normal gonads. And as you can see by the incidence here, this is a rare disorder. So the incidence is something between 1 out of 10,000 to 1 out of 40,000 individuals. And this diagram shows the steroid biosynthesis of the adrenal cortex, and I'm sure you are aware of it. So with deficiency of 21 hydroxylase, which is acting here, as you can see, there will be a deficiency of glucocorticoids like cortisol, but also deficiency of mineral corticoids like aldosterone, but instead an overproduction of androgens, because the normal feedback regulation by cortisol on the pituitary and ACTH doesn't work. So there will be an increase in ACTH, which will stimulate androgens. It will, of course, also stimulate the other pathways, but because since we have this block here, there will be an increase, for instance, in 17-hydroxyprogesterone, but also of progesterone. And this disorder is treated mainly by glucocorticoids, but many patients also need mineral corticoids. And by this treatment, there will be a decrease in androgen production. So this will mimic the normal negative feedback regulation. And there are different severity of CAH, and we used to categorize them into the most severe form, the salt wasting form of CAH, the simple virilizing form, and the non-classic form. And these three clinical forms of CAH are linked to specific mutations. So there is a close relationship between the severity of CAH and different mutations. And with the salt wasting form, there is a deficiency of both cortisol, mineral corticoids, and an increased production of androgens. And there is also salt waste. But with a simple virilizing form, the cortisol deficiency is not that severe, but there, and there is also an overproduction of androgens. With the non-classic form, this is more dominated by an overproduction of androgens, and this form could mimic polycystic ovary syndrome. Okay, so in the most severe case of CAH, this could lead to prenatal genital virilization of a female, as you can see in this picture here. This child has an enlarged clitoris, but also fusion of labia here, and a common urogenital sinus. Previously, this was early reconstructed by surgery, but today we do not recommend this because the patient groups have argued that they want to take this decision themselves. So today, a late reconstruction could be done if it is requested by the patient. So this is very important that the patient is involved in this decision. Okay, in some cases, the patient could be diagnosed later in life, and then she can have symptoms of virilization. It could also be so that she's undertreated by cortisone and then have still an overproduction of androgens. And this could cause a deep voice, breast atrophy, as you can see in this picture, hirsutism, increased body hair growth at specific localizations, increased muscle mass, amenorrhea, and an enlarged clitoris like this. And of course, this condition could affect both sexuality and identity. And what we know is that homosexuality is more common in women with CAH, but particularly in those with the most severe form, the salt wasting form of CAH. And this is illustrated in this picture here. It's from a Swedish study by Frisén et al. And the dark bars are showing homosexual orientation. And in total, 19% of the CAH women were homosexual in comparison to 2% in the control, as you can see here. And the highest frequency of female homosexuality was in the most severe genotype, as you can see here. In this group, it was also most common that women were single and had no relationship. It's also known that women with CAH, that they have lower sexual activity and higher frequency of dissatisfaction with sexual life. And that could include arousal problems and also reduce orgasm capacity. And it is also reported that they have a high frequency of pain during intercourse, which of course could be due to previous surgery. And we know that genital surgery is associated with impaired sexual function in these women. Regarding identity, the overall majority of these women has a clear female gender identity, but in a few cases it could be changed to a more male identity. So what about fertility? Well, reduced fertility and birth rate have been reported in several publications in these women. And once again, particularly in those with severe forms of CAH. And the underlying causes to this could be various, including anovulation, there could be anatomical barriers, but also various psychosexual factors. But the general perception today is that women with CAH who wish to conceive, they do conceive, but it may take a longer time and they may also need some kind of fertility treatment. We have performed a Swedish population-based national cohort study and investigated reproductive and perinatal outcomes in 272 women with CAH. And we found that 25% of these women gave birth to at least one child, compared to 46% in the control group. And this was clearly significant. The women with CAH also had significantly lower number of children compared to the control group. During pregnancy, gestational diabetes were more common in women with CAH, and you can see the figures here. And cesarean section was also more common, probably due to planned cesarean section in those who have undergone genital surgery. But what was positive was that we found that perinatal outcomes in the children were comparable to controls. So we found no increased risk or other complications in the children. Okay, now I will move on to another case of DSD. This concerns a 17-year-old girl with primary amenorrhea. And we know from her medical history that she had undergone surgery for inguinal hernia at age 6, but otherwise she was healthy. Her weight is 64 kilogram, height 169 centimeter, breast development corresponding to 10-3, and she has sparse pubic and axillary hair. And here you can see her laboratory results. FSH 14 units per liter, LH 29 units per liter, estradiol lower than 150 picomole per liter, testosterone 14 nanomole per liter, DHEAS 19 micromole per liter, and androstenedione 12 nanomole per liter. In this case, you can see that testosterone is clearly elevated, and it is actually in the male range, which is much higher than the normal range. So what could this be? What kind of DSD could this be? In this case, she was diagnosed with complete androgen insensitivity syndrome called KAIS, and previously and this woman, she has not ovaries but testes, and she has a normal male karyotype, XY karyotype, but the phenotype is female. She has primary amenorrhea, and she was presented by very sparse pubic and axillary hair, and a little bit taller than the average woman. And when we investigate her, we will find that she has a shorter vagina than normal and an absence of uterus. This is a maternal X-linked recessive hereditary disease. And the incidence is even more rare than for CAH. It's about 1 out of 50,000 individuals. And this condition is caused by a mutation in the androgen receptor gene, which is localized on the X chromosome. So how do we manage these patients? Well, there is a small increased risk of germ cell cancer in the testes, which are usually localized in the abdomen or in the inguinal canals, as in the patient I told you about. And previously, early gonadectomy was recommended for these patients. However, patient support groups, they are advocating for informed consent prior to any decision of surgery, because it has been reported that they feel less vitality and decreased libido after gonadectomy. And today we know that the risk of germ cell cancer is not very elevated. So what we recommend as a first step is to take biopsies of the gonads. And preferable is to wait with gonadectomy after puberty. But this should be performed after careful discussion with the patient. And it has been reported that 60% of adult patients with KAIS decline gonadectomy. And if gonadectomy is performed, then the patient will need estrogen replacement. before gonadectomy, she has the high levels of testosterone, which will be converted to estrogen by peripheral conversion. But after gonadectomy, she will need estrogen replacement. What about sexuality and fertility in these women? Well, low sexual desire has been reported in women with KAIS, as well as reduced orgasmic capacity and dyspareunia. And usually they have a little bit shorter vagina than normal. And this hypoplastic vagina could be treated with dilatation. And this should always be the first choice of management. And surgery is rather very, very seldom needed. Furthermore, since this patient also could have a low libido, and particularly after gonadectomy, interestingly, a recent randomized controlled trial indicates a positive effect of testosterone on sexuality in gonadectomized women with KAIS. This is quite interesting since they are considered to be complete androgen insensitive. They can anyway respond in some way to high levels of testosterone. But regarding fertility, it is more difficult because these women, they have no uterus, so therefore they cannot bear a child. And although the gonads of the individuals have normal testicular morphology and are functioning in the way that they produce testosterone in the male range, as far as I know, there is no detection of functioning germ cells in these women. So finally, what about identity in women with KAIS? In general, they have a clear female gender identity, and they show a female typical gender role behavior, and are most often sexually attracted to men. And they used to be called super females because many of these women, they are tall and slim, and they have a nice breast development and never acne or hirsutis. So many of these women are very beautiful. So even if they look very feminine, they may report feeling less feminine. And it is known today that there could be a great need of psychosocial and psychosexual support for these women. So now I'll come to my last slide here. So the take-home message from this presentation is that disorders of sex development are rare conditions which can severely affect both sexuality and fertility. And sexuality should be specifically addressed in the care of these patients, and consultation of a sexologist might be needed. The fertility potential differs considerably between different types of DSD, but also among patients, and should therefore be assessed individually. And I would also like to remind that do not perform genital surgery or gonadectomy without prior informed consult of an adult patient and discussion with the DSD team. Thank you for your attention.
Thank you. Thank you very much, Angelica, for this beautiful presentation. Can you close your, yes? And then I would like to invite Rossella. She will speak on another area of this complex topic. And Rossella, you have the microphone. and please make your intervention. All question and answer, we will answer to the question later on at the end of both presentation.
Hello, everyone. Thank you, Professor Genazzani. Thank you, Angelica. I believe you see my screen. And my topic today is endocrine condition and female sexual function. And as Professor Genazzani said very well at the beginning.
Excuse me, Professor Nappi, could you please open your screen in presentation mode? Thank you.
Yeah, now is better.
Thank you.
Sorry, usual stuff in this virtual meeting. So we said at the very beginning that many medical conditions are relevant to sexual function, and endocrine condition is no exception. As you can see from all this circle, we are used to talk about estrogen deficiency, androgen deficiency, the impact of contraceptive hormones and anti-hormones on sexuality, and we talk less on the impact of other endocrine systems. We have heard a little from Angelica about adrenal disorder. We will skip the metabolic syndrome for the sake of time, and we will focus more our attention on hyperprolactinemia and thyroid dysfunction a little bit. Overall, it's important I remind to everybody that as a gynecological endocrinology society, we are very much involved in studying and treating women's sexual response, because the endocrine milieu is essential, is the most important organic factor affecting the whole substrate of the sexual response, the neurovascular substrate, the neuromuscular circuitries, and overall the general well-being of our patient from adolescence to menopause and throughout the aging process. Of course, intrapersonal and interpersonal determinants are also relevant, and we will see that there is a strong interaction between biological substrate and psychosocial aspects. Usually, when we think about hormones, we always think about the biological substrate, and so what we name spontaneous sexual drive. But we know for sure that there are many other aspects taking place and influencing the entire positive circle of the sexual response. So essentially what I want to say that when we deal with something happening within the central nervous system, within the brain, what we name sexual drive, we may influence also the peripheral response in sexual function. And also when we deal with an impaired peripheral sexual response, we may affect in a vicious negative circle what is happening at the central level. And of course, we have all the other aspects, including the partner, that is important. And maybe we will devote another webinar to the role of the partner in women's sexuality. When we deal with the traditional steroids, sex steroids, we have to remember to everybody that estrogen, testosterone, and even progesterone affect the neuroendocrine response at the level of the central nervous system. So the desire is the most affected, but it's important to underline that even mental arousal and orgasm and satisfaction within the central nervous system are affected by any change in the sex steroids environment. Of course, hormones that prime the brain to be selectively responsive to sexual incentives, creating a neurochemical state that is more likely able to induce a sexual response. And so it's really the brain throughout the balance of neurotransmitters, the most important one we will see in a minute, dopamine and serotonin, but also noradrenaline and GABA, they are involved. And in this context, you will see that other endocrine systems, they may play a role. At the periphery, essentially, is the same story. Estrogen, testosterone, and progesterone, they may affect the balance of neurotransmitters. And again, you see and you recognize serotonin, but also noradrenaline, even acetylcholine, and other neuropeptides and neuromodulators. And the same story is there, because these hormones, they affect the balance of neurotransmitters influencing sensation, vasocongestion, lubrication, and orgasm. And sex hormone exert a trophic effect and modulate the threshold of tissue response to these external and internal stimuli throughout the neurochemical array. And even in this context, other hormones play a role. So nowadays, when we think about this threshold of response to internal forces and external incentives, we have to put everything in the same cartoon, because you see here that we have a central threshold to affect what we name mental arousal, and a peripheral threshold that we name genital arousal. This threshold is strongly determined by genetic and epigenetic determinants, and internal forces, including all the hormones that can impinge on this threshold, are extremely relevant in the balance between excitatory and inhibitory signals affecting the sexual response and behavior of individuals. This threshold is quite complicated, but I will try to make it simple. You see here that when we think about the organic factor affecting the excitatory signal, we should include many neurotransmitters, but also some neuromodulators such as melanocortin and oxytocin, a neuropeptide that is very, very important in reproductive endocrinology, we will see in a minute. But I would like to remind you that also psychosocial and interpersonal factor, something that we see, you know, that has to do with psychology, with social science, has to do with biology. Because when we have a positive intimacy, when we share the same value, when we are in romantic positive relationship, and when we have positive experience and behavior, we activate these neuromodulators. And so this is biology, my dear friend. On the other hand, we may have important inhibitory signals, and we are aware that opioids, endocannabinoids as mediators, and a very important neurotransmitter, serotonin, is exerting inhibition on the central system and may affect reward and satiety. But also these biological signals, they mediate the psychosocial negative environment in sexuality, relationship conflict, negative stress, negative beliefs about sex, and negative experience and behavior. So at the end of the day, it's really the balance among all these factors that is affecting sexual response in women. And when inhibitory signals, they are stronger, they can cause the most common condition that is within the central nervous system and is affecting the sexual response overall, that is what we name hypoactive sexual desire disorder. And we know very clearly from the literature, this is a cartoon I produced several years ago, but is still extremely valid, that prolactin, it's really in between these two major systems affecting on one hand motivation and on the other hand satiety. That is dopamine on one side and oxytocin on the other side. You see here that dopamine is the neurotransmitter modulating anticipation and motivation and sexual performance, and may mediate as well sexual reward. And so when dopamine is there and is very active, people, they really feel, and this is true for male and female, we are talking about female today, it's people, they are very keen to enter sexual intercourse. On the other hand, oxytocin is essential to modulate all the neuroendocrine reflexes that facilitate satisfaction, both mentally and physically. Indeed, they promote lubrication and orgasmic contraction, but they also stimulate bonding and relationships. So we may say that oxytocin is really the neuromodulator of affection and attachment in human beings. But prolactin is extremely interesting because prolactin is a hormone, we will see better in a minute, that increases following orgasm. And when it increased in the circulation, just transiently inhibits sexual desire and arousal. But prolactin reduces also vaginal receptivity. We have a very important model in OBGYN, the secondary amenorrhea that we have during lactation. So in that time in which female, they have some kind of, they are refractory to sexuality because they have to foster their baby. So prolactin is extremely interesting because it's a hormone that is involved in the circuitry I described you before. This circuitry we can study nowadays, for example, with functional magnetic resonance, and we know that when we have an increased activation of dopamine in the brain and we have a decrease of serotonin activation, we may have a normal sexual function, whereas when we have an increased inhibition because we have a decreased activation, and as you can see here with the red spot and the green spot, we may develop some kind of low sexual desire, hypoactive sexual desire disorder. While this is happening when we talk about prolactin and sexual function, because as I said, the prolactin levels increase following an orgasm. And it's very interesting that we have a lot of data out there suggesting that these occur either with masturbation or coitus, but it's interesting that when you have sexual arousal without orgasm in healthy women, this is not occurring. And you have to think about that plasma oxytocin level rise during and following orgasm in conjunction with prolactin. But we know that the quality of sexual experience in women correlates with this post-orgasmic prolactin surge. And this is extremely strong when we have, for example, vaginal intercourse following penile vaginal stimulation. And this is higher than following masturbation. So when we think about prolactin, we have to think about that it's extremely difficult, for example, to measure oxytocin in the plasma because it's a very little teeny concentration in the blood. So it's very difficult to study what is happening in the brain. Whereas, for example, it's easier to study the transient release of prolactin in order to understand better what's going on at the level of the central nervous system. Because prolactin may be a biomarker of sexual satiety. And so if we want to study sexual function in human beings, prolactin may be a good candidate because it's very important. I remind to everybody that one of the reasons why prolactin has been so little studied in sexual medicine, especially in physiology, is really because even though prolactin has multiple role at the central nervous system, we know that all the study that we can conduct in animal model cannot be easily translated to human being. And this is very evident in the field of sexual medicine, in which something that comes from relationship and psychological environment is very much important to influence sexual behavior. And this is the reason why a very recent survey that review, that was conducted by an Italian group said that this issue has been very poorly investigated, and especially the link between prolactin abnormalities and domain of the sexual response has been poorly studied, because prolactin has been studied for reproductive function and fertility, but not so much for sexual health. And if it's true that prolactin has an inhibitory role on sexual desire, arousal, and orgasm, we demonstrate that only in very high hyperprolactinemic states, such as what is happening with pharmacological manipulation with psychoactive agent. But we don't know so much. with the normal variation of prolactin during the menstrual cycle, for example, or in other endocrine conditions. And just to summarize what we have said, it's important to remember that elevated prolactin may alter sexual desire and arousal via a direct neuroendocrine effect, impairing that negative dopaminergic influence and impairing that positive serotoninergic control of prolactin release. But also we may have indirect endocrine mechanism, such as, for example, secondary effect of hypoestrogenism, for example, on vaginal tissue, as it occurs during amenorrhea or during other hypoestrogenic states. And just to remind to everybody that nowadays, when we think about a psychoactive agent inducing hyperprolactinemic states, we distinguish this drug, this psychoactive agent, in drugs that can spare prolactin, or at least they can increase less prolactin in comparison to those that can increase more. And this is a beautiful cartoon with a lot of asterisks in which you can recognize what we name first generation antipsychotic. Think about, for example, haloperidol, that is widely used in the world to treat this kind of patient. But unfortunately, these women, they have significantly high level of prolactin, and so we know that they have an impairment in reproductive function, but they may have as well a strong impact on sexual function. And then we may have other psychoactive agents that can spare the sexual function. And so we can really treat patient trying to spare the sexual function with one drug or another. So it's important when we do our medical history to take into consideration all the different class of this drug. Another very interesting aspect, it's really that we lack the knowledge on transient elevation of prolactin, what we name functional hyperprolactinemia. This is very common under stressful situation, but it's a common knowledge that we say sometimes that women, they are under stress and so they have poor desire. But you see, when you have this mild condition of prolactin, probably you may reverse if you correct pharmacological this situation. Also, we know very little about repeated nipple stimulation. We know that for some women, for example, nipple stimulation is important to reach arousal and orgasm. And think about in our clinical practice, maybe we measure prolactin, we do not consider these, let's say, non-coital sexual behavior of women. So I think in the setting of gynecological and endocrinology and reproductive medicine, we should think about all these modulators. They are related to sexual behavior. They may affect our practice. Another very interesting point that sometimes hyperprolactinemia, especially functional hyperprolactinemia, may be associated with some kind of impairment in thyroid function, even subclinical hypothyroidism that can be important and may independently affect sexual function. Another interesting findings, it's really that when we have hyperprolactinemia of any grade, of course, it's stronger when we have the model of pituitary adenoma, even secreting adenoma or non-secreting adenoma. We may have some cascade, negative cascade on other steroids, not only estrogen and androgen, but also glucocorticoids, and this can be involved in sexual dysfunction. Another interesting aspect that has not been investigated in women, but you know, if we want to stimulate residents and PhD students, I think it should be studied according to the literature, is hypoprolactinemia, because we know that hypoprolactinemia is strongly linked to premature ejaculation and erectile dysfunction in male, but we don't have any data out there available regarding female sexual dysfunction. Another aspect that we can touch on this topic is really something that has to do with the pharmacological manipulation in the treatment of hyperprolactinemia. As I told you, hyperprolactinemia, of course, may be a treatable cause of FSD. We know that when we modulate with dopaminergic drug, we can improve the female sexual function index. That is the most used questionnaire, validated questionnaire, able to assess different domain of sexual function. And it's important I underline that we, as you know, we don't have so many drugs to treat pharmacologically hyperprolactinemia. We have the dopamine agonist cabergoline and the old bromocriptine. And we know that cabergoline is superior to bromocriptine in affecting both male and female sexual functioning and should be preferred, according to the literature, to treat hyperprolactinemic women with sexual dysfunction. And we have also some data, open label study, suggesting that when we have women, they develop hyperprolactinemia not only due to a microadenoma or a microadenoma, but also to antipsychotic drug, we can successfully improve sexual function in these women. However, there is not enough evidence to support a recommendation that the treatment of hyperprolactinemia will improve in every woman female sexual dysfunction, probably because we have always to take into account other psychosocial aspects. Which one should be point of awareness for future study on the role of prolactin in women's sexual function? This is something we summarize in a manuscript we have in preparation with my dear friend Alessandro Genezzani, that we have to consider that prolactin should be a potential cause of FSD only when we do not find a real hyperprolactinemia. But as I told you, when we may face mild functional hyperprolactinemia in some states, some physiological states. Think about all the fluctuation we may have in prolactin during the menstrual cycle, during menopause transition. We know that some pill, they do not induce a really hyperprolactinemia, but may induce a mild increase of prolactin. We know that some fertility treatment may transiently affect prolactin, for example, during IVF treatment. Even many stressful situations associated with reproduction we never think about, such as polycystic ovarian syndrome, premenstrual syndrome, some cases of unexplained infertility, but we know also the strong stress that is associated with endometriosis, miscarriage, adaptation to early menopause, or even puerperal adaptation, and daily life negative emotional states associated with the new role of women may contribute to some extent to the manifestation of FSD and can be related to modest increase or even decrease of prolactin. So prolactin should represent a soft biomarker in the context of the biopsychosocial model, in our opinion, and we should address more this issue during reproductive lifestyle and beyond. But of course, everybody of us involved in reproductive medicine knows that there are some kind of methodological issue in measuring minimal change of an hormone that is so highly sensitive to stress. And so this is probably one of the reasons why this stress issue have hampered research in the field of sexual medicine, and we really need to cannulate a vein in order to study baseline condition of prolactin in order to assess the topic of functional hyperprolactinemia. However, my dear friend, when we want to diagnose a sexual dysfunction, especially hypoactive sexual desire disorder, we should include prolactin, and we will see in a second to conclude the thyroid function in the workout we should do to diagnose a female sexual dysfunction. And a part of sexual history that should include always any kind of events associated with reproduction, and of course a general medical history that should include all the medication we have seen, antidepressants, so very relevant to sexual function. We should include a measure of prolactin and thyroid evaluation in order to assess from a biological point of view the biological basis of sexual dysfunction. As I told you, prolactin is strongly related to TSH, and because these are two twin hormones, they goes together hands in hands. And even when we correct subclinical or clinical hypothyroidism, we may affect prolactin level, and we may have some consequence to sexuality. And I want to share with you, to conclude, two major studies that has been recently, very recently published on the Journal of Sexual Medicine. They are meta-analysis of studies using the female sexual function index. And you see here that the effects of hypothyroidism and subclinical hypothyroidism on sexual function. And when we compare with healthy controls, patients with hypothyroidism scored lower in all the FSFI dimension: desire, arousal, lubrication, orgasm, satisfaction, and pain, especially in lubrication. And when we consider the domain of female sexual function index, we don't see an effect of subclinical hypothyroidism on their overall score, but we see some effect on arousal and orgasm. And keep in mind that these two dimensions are strongly related to prolactin, as I said at the beginning. Another interesting point, a last point, but that we should consider as well in clinical practice, is that overt hyperthyroidism, but also mild hyperthyroidism, I do not report in this table, are associated with a significantly lower FSFI value in terms of FSFI total score, subscale sexual arousal, lubrication, orgasm, and satisfaction. And so from this meta-analysis and systemic review of the literature, you can say easily that even though this is more clear in male, this is true also in female, and women with hyperthyroidism, they have twice the risk of developing female sexual dysfunction. So I think that to study more the endocrine factor is very essential for us to understand better women and couples in clinical practice. Thanks a lot for your kind attention.
Thank you very much, Rossella, for that beautiful presentation. Also because we have introduced some new data too. And we are now some time for the discussion. We have received several questions from on both topics. And I would like to start with one question, which is for Angelica. What are the causes of reduced fertility in congenital adrenal hyperplasia?
Well, we believe that there are many causes. First of all, what is most obvious is, of course, the hormonal factors. And for instance, both androgen excess from the adrenal glands and the ovaries could cause anovulation. But we also believe that increased progesterone, if the patients are undertreated, then progesterone will be increased also in the follicular phase of the menstrual cycle. And that could cause a mini pill effect on the genital tract that could affect fertility. Then, of course, many patients, they have undergone genital surgery, so they could have problems to perform vaginal intercourse and have a lot of pain, so they avoid sexuality. And then we should not forget that some of these women, they may not want to have children, and we have to respect that. So there are many, both biological but also social factors that could explain this. But I think, as we believe now that those who want to become pregnant, they will succeed, most of them, and that is a very positive knowledge we have now.
Thank you very much. And then now one question for Rossella. This should be prolactin be measured at any time in a woman if a woman report a sexual symptom in an OBGYN consultation?
In my opinion, yes. From personal experience and some data that now we are collecting routinely in our practice, we should measure that. The problem, as I said, I will explain better, that of course, if you just do a single blood sample, maybe this is not reliable. We know that women, they are under stress. We have always to consider the phase of the menstrual cycle, as you know very well. And so this is the real problem. But in my opinion, if a woman entered the office and she say that she has low desire, low arousal, poor lubrication, we should go on at least to do what we name a mini curve. So we really take the antecubital vein, we just put in place a needle, we wait 20 minutes in a resting environment, and then we take a blood sample. And if prolactin is, as you know, also different laboratories, they have different range. But when we are in that gray zone that usually is in between 20 and 30, 35 nanogram ml, and of course even higher, and then we have to do all the workout to exclude upper than 50 nanogram ml, usually the presence of a microadenoma, we should correct, even with very little dose of cabergoline. We are now producing some data on that, and you have to believe that this is a very exciting topic, because we may have an indirect improvement and availability of androgen, for example, and you may really do something simple, low cost and useful to the patient. And of course, at the same time, you have to rule out other psychological aspects and even conditions such as mild depression, because in mild depression, mild anxiety, and so on, we know that prolactin can arise during the day, even if it's not so elevated. But this is something that day by day will slow down the sexual responsive women. This is, believe me, a very exciting topic nowadays, in my opinion.
Thank you. And then now back again is a question raised by Jane Depty, and which is go back to the pregnancy. If you have a congenital adrenal hyperplasia who she became pregnant, what they should be the problems, possible problems during pregnancy, and how to test in the newborn and how to check the newborn after pregnancy?
Well, during pregnancy, I think the most important is to consider the increased risk of gestational diabetes. So the patient should be managed according to this, to perform an oral glucose tolerance test would be good. But what we found in our studies and what has been reported is no increased complications for the babies. So they have comparable birth weight, birth length, head circumference, and no increased complications. And I think that is a very positive finding, really. So the only thing we know today is the increased risk of gestational diabetes during pregnancy.
Thank you. And then now one question for Rossella. She's coming, the question is from Mariana Bignardi Halla. And also I would like to bind together with a question originated from Cesar Cafatti. Mariana, she asked, do you realize which minimum levels of prolactin could start making those changes in sexuality, one side, and in the other side, Cesar Cafatti, how we manage sexuality in menopausal women that cannot use estrogen and testosterone? It is recommended dopaminergic natural medication. Do you have any experience if they are useful? Please.
I thank you both for these two very interesting questions. You know, we don't have really a blood level nowadays in the literature we can suggest. Also because we have to think about that there is a neuroendocrine impact of prolactin. So probably blood level, they reflect what is happening within the central nervous system, but not always. We have a beautiful experiment that was performed several years ago by the group of Rick van Lunsen and Ellen Lan in the Netherlands, in which they realized that during menopause, and this is the reason why your question is so pertinent, we know that there is an increase, a little bit of prolactin during menopause, and this is relevant to mental arousal and genital arousal of women, irrespective from the presence of estrogen or androgen replacement therapy. So by modulating prolactin during menopause, we can maybe increase sexual desire and arousal by lowering the level. But you have to believe me, there are no published data on that. We recently revised with Alessandro this, and this is the reason why I decided to give this clue in the webinar to stimulate research in our field.
Thank you, Rossella. Then now for Angelica, we have also an articulated question which rise from Christian Kopacek and others, and also which is related to how can we improve sexuality in women with congenital adrenal hyperplasia, and what it should be the impact of surgical approach in the sexuality.
Mm-hmm. Well, first of all, we know that testosterone is important for libido in women, not only in men. And if we overtreat women with CAH, with cortisone, then we will lower androgens perhaps too much. So from being hyperandrogenic, they will be hypoandrogenic. In my patients, when they complain of low desire, I think it's important to try to reduce the cortisone dose to increase the level of testosterone a little bit. So that is one case, because many patients, they are overtreated actually by cortisone. And then what about surgery? Well, we know that when we previously made this reconstruction early in babies, we know that they have been traumatized during childhood, examined several times over and over again, and they don't understand why. They just know that they look different. And this could be psychologically stigmatized, I think. So this we should really avoid, and we have changed our practice now, so this should not be done anymore. But sometimes an adult patient wants to undergo some kind of reconstruction because of enlarged clitoris or something, or be very narrow. And then we should discuss this, and with her consent, we could do that kind of surgery. And during the last years, when we have done this very restrictively, then we have noticed that the women who undergo this, they are satisfied. So in some cases, we can do it.
Thank you very much. And then now for Rossella, another question, which is also important going in the daily practice in gynecology. Are there any data suggesting a role of prolactin in hormonal contraception-induced menstrual dysfunction?
This is a very good point. As you know, as I said briefly, contraceptive hormones we have nowadays, they increase only a little bit, or they do not increase at all according to the data we have prolactin. This is the reason why even the recommendation of the Endocrine Society, they indicate that we can use hormonal contraception in women with, for example, microadenoma if they are well controlled by bromocriptine or cabergoline, because they do not stimulate with this content of ethinyl estradiol or estradiol the proliferation at the level of the pituitary. But of course, we cannot exclude, as I propose, that even mild increase of prolactin that is not abnormal, but is just different from what the woman has usually, may play a role in some sexual dysfunction in women. Think about when women, for example, they develop mastodinia. This is a symptom that sometimes we relate to estrogen content, but maybe it's just because you have some fluctuation of prolactin. And we said how much the breast is important during sexual intercourse and sexual contact with your partner. So if we put all this information together and we want to design study on sexual function and behavior, you understand how this is difficult. We have here Angelica that published on the topic of hormonal contraception and sexual function. She can explain to everybody how it's difficult to do this study assessing the role of hormonal contraception on sexual function. I don't know, Angelica, if you want to comment on that.
Oh, in that study, we found a decrease in free levels of testosterone, but interestingly, there was no association between the decrease in testosterone and the decrease in sexual function. So, I mean, this is much more complicated.
Yeah, and maybe it's an effect in the brain. And
thank you. And we have just also a question now for Angelica. This is the question is: do gonadectomy after affect sexuality in women with congenital androgen insensitivity syndrome?
Yes, we have now increasing evidence for this. I mean, first we realized that patient reported this spontaneously, that they felt different after gonadectomy. And if we think of this, I mean, they have the diagnosis of being complete androgen insensitive. And even so, they feel a difference after gonadectomy. And now we have studies also demonstrating this, that after gonadectomy, they may experience a reduced sexuality and also reduced vitality. And this most likely is related to the absence of testosterone. And therefore, I think it was really interesting, this recent randomized controlled trial in patients with complete androgen insensitivity, showing a positive effect in these women with testosterone on sexual function. So I think, I mean, now we give them estrogen after gonadectomy, but I think in perhaps many patients, we also should give testosterone.
Yes, and I would like just to add, just Angelica again, on this point, it's a question from Chris Creatura, and I would like also to add a personal question. Creatura asked, do these patients, then the patient gonadectomized and also treated, experience earlier onset of dementia or heart disease? Question. And my question, how long you believe that during their life have to be maintained in gonadectomized congenital androgen insensitivity syndrome patients, even above the age of the menopause?
How long they should be treated with hormones?
How long should be treated, and if in those patients there is an earlier onset of dementia or heart disease?
As far as I know, there is no report of early onset dementia. And I mean, usually they are gonadectomized quite early in life. We try to postpone it after puberty, but usually they are undergoing this quite early in life. And if we start to treat them with estrogen, for instance, when they're 25 or something like that, and they continue, probably they should continue lifelong. And as far as I know, there is no report of an increased risk of dementia also. And for testosterone treatment, we don't know.
Thank you. And then now for Rossella, you mentioned levothyroxine. And then the question is, has levothyroxine been proven effective in restoring sexual function in women? Certainly in hypothyroidism.
Yeah, there are data that were included in that systematic review I showed that reported that by restoring the thyroid function with hormones, you will rebalance sexuality. But of course, we cannot know if this is really an effect on sexual function by itself or is an indirect effect on a more general well-being of our patients. So what we have to consider, in my opinion, is the reverse. Anytime we see a person with a sexual dysfunction, we should consider the presence of subclinical hypothyroidism or hyperprolactinemia together or alone, and to try to restore the good hormonal environment. And then, as we do with testosterone, when we, according to the guideline, you restore the environment, if after 3-6 months you don't see a real clinical improvement, it means that other mechanisms are taking place. But of course, we should have a patient that it's really well balanced. And I saw in the chat that people, they are also very much interested in natural or bioidentical hormones. I'm not an expert on that, but for sure, for example, we know that Aniocastor or Damiana, or all these drugs, they are capable of helping women to adapt to mild change in terms of prolactin, and also to try to restore the good balance in the androgenic milieu can have some good on sexual function. We have to try without eluding our patient, but just to say, okay, if we are not able to find an explanation, we have some women, they enter our office and say, everything is fine with my partner, everything is good in my life, but something is happening to me. We have to check for these two neglected endocrine system, because we will learn something from our experience.
And then now a very simple practical question for daily practice from Zdravko Kamenov, Dr. Kamenov. He asked, how should the corticosteroid treatment of congenital adrenal hyperplasia pregnant women be performed during pregnancy?
Usually we do not change the dose, not in the beginning of pregnancy, but from about half of pregnancy, we increase the dose a little bit, and they will need it also for the delivery. And we always give extra cortisone during delivery. Otherwise, there's a big risk of cortisol deficiency. But of course, each patient should be carefully monitored during pregnancy.
Yes, thank you very much. And then now from Argentina, Maria Marta Calvo asked Rossella, what is your opinion about sulfato DHEA and what is the appropriate dose, DHEA sulfate? And as androgen suppletive therapy or as pre-hormone therapy during pregnancy, in women who have a female sexual dysfunction?
I think Professor Genazzani should answer to your question. As you know, according to the guidelines we produce on androgen, DHEA is not considered in randomized double-blind placebo-controlled trial an effective treatment specifically for sexual desire disorder on female sexual dysfunction. But we have several evidence out there that DHEA may be useful even at very low dose. Isn't true, Professor Genazzani? 10 milligram or 50 milligram orally to improve several aspects of well-being in women. As you know, the HEA is based on the concept of intracrinology, and probably every single individual possesses his own array of enzyme to metabolize the HEA within the cell. So this is the reason why the response of the patient is so variable, in my opinion. I have patients that improve significantly with the HEA, and others that do not improve so much. So I believe that it depends on the HEA preparation, on that particular individual metabolization. What do you think about Professor Genazzani?
Yes, I think first of all that thinking to DHEA sulfate, we have to measure DHEA sulfate in basal condition. Patients who still have normal concentration, you cannot believe that supplementation can improve. But you can find a huge number of individuals with very low concentration. This is not only in elderly population or after menopause, but also in the young population. And in those patients, we have seen that after at least 3 months of treatment, you have to wait the time. We have a positive effect both on sexuality aspects, but also on biological aspect of the sexual organs, because as Rossella was mentioning, intracrinology indicate you that you have a conversion of the HEA to other steroids than androgen and estrogen according to the local presence of the enzyme responsible for that. Then it is important the enzymatic pattern of the individual at a different level and its sensitivity. I think it's pity that Rossella mentioned that we have no double-blind placebo-controlled study because it's a natural substance and nobody wants to spend money to see if it is efficient or not, and then everybody can repeat and can put on the market the same drug. But we have done long studies since nearly 20 years on the positive effect of that. But I don't want to go on that one. And then I would like to make a conclusion with 2 small questions. One is important, Angelica, because it's also important to think what happened in the fetus during the treatment. The question is, from DeepTGI, which corticosteroids are recommended in pregnant women with simple virilizing cortical adrenal hyperplasia, dexamethasone or prednisolone? Please, if you can answer on that one.
We prefer to give short-lasting cortisone, not dexamethasone, because it's very difficult to monitor the dose. And prednisolone is also a middle long-lasting, so it is most preferable to give actually hydrocortisone.
Okay, thank you.
Then you have to give it 3 times a day and sometimes 4 times a day.
Yes, this is very important because otherwise at birth we can have some deleterious effect on the adrenal of the fetus. And then I thank you. And then a last question for Rossella. And the question is that one, can you believe that we have to check prolactin in women who complain of female sexual dysfunction? And if so, when we have to check, in follicular phase or in luteal phase?
I mean, as you know very well, during follicular phase, usually prolactin is lower, and it's increased as a small peak at the time of ovulation, and then it stays a little bit higher in comparison to the follicular phase during the luteal phase under the effect of estradiol and progesterone. So in my opinion, if we want to see if a woman has a mild hyperprolactinemia, we should consider the follicular phase as baseline, but we have also to consider that if this woman, they have premenstrual syndrome, they have a low desire, especially during the luteal phase, we should go when the prolactin is high and try to see if this prolactin is going up the threshold of normality according to your laboratory. So we really need to consider both phases, in my opinion.
Thank you very much for being with us. I wish
Thank
for
you.
a COVID-free time, happiness, health, and all the enjoyment that you can have by your investigation and staying with your patient and your family. Thank you very much.
Ciao.
Bye-bye.
Ciao, ciao. Bye-bye.